Hi, and welcome to the Soul and Survival podcast with Grant and Louise Bentley. We have run the Victorian College of Classical Homeopathy since 1995. We are both qualified practicing homeopaths, and Grant is also a naturopath. Together, we discovered a link between energy and facial structure based on traditional ideas from homeopathy that have roots going back 200 years. This project is called Homeopathic Facial Analysis, or HFA for short, and has been the cornerstone of clinical diagnosis and training courses since 1999. Between us, we have written and produced 7 HFA books, including Soul and Survival. Soul and Survival is the philosophy of energy influencing matter and how this energy forms individual facial structure, our unconscious drives and fears, our life patterns, and universal time cycles.
Hi once again, everybody. Welcome to Soul and Survival. Hi, Louise.
Hi, Grant. How are you today?
I'm okay. Now, last week you were saying we got very passionate. Did it get too passionate? I can get a little over the top at times.
Don't worry about it. So can I. Not a problem. I think we all have the right on our own podcast to get a bit passionate when we want to.
Well, I think we were just talking about the differences of the way people practice. But one of the things that you really understand is that homeopathy for a long time has been a tapestry of different ways of practice. And I'm really not so sure. In fact, I could put up a very good counter-argument to a pro-argument that it's been its weakness rather than its strength. I think individuality is a really good thing when it comes to the practitioner treating the patient, but I'm not so sure it's a good thing when it comes to ways of practice.
And certainly ways of learning. It would be nice to think that everybody started with a somewhat similar curriculum where the basics were there. And we could argue, of course, there'd be lots of arguments about what they should be and how far you go, but just, basics like how to take a case, how to repertorise, what a symptom is, what a rubric is, understanding, how provings work, maybe in your college being part of a proving, that's actually a real eye-opener.
Yeah, and conducting a proving,
it's
that
huge.
Was a big one too.
Well, we did that a few times, and it's a huge deal, taking a dozen or so people and putting them through a proving and recording everything and then discussing it and everybody having their own supervisor and making sure that their normal state of symptoms is differentiated from the remedy's state of symptoms, and then how you allocate them. And I remember we met Dale Emerson when he was with Radar in Belgium, and he took us to see this lovely office where these couple of the ladies were sitting there, and their whole job was just examining information sent in from homeopaths around the world and working out where to allocate it and how to reference it. So, there's some great people out there doing really good things, and considering we do it all on a shoestring, it's incredible that homeopathy's got as far as it's got, along with the attacks. But we'll go back to the internal, because I really wanted you to talk a little bit about some of the skill set that you apply to the clinic. Are you okay with that?
Mm-hmm.
All right. Well, case taking's kind of number one. You got to take the case before you do anything else. Mm-hmm. And you've done it for many, many years. You've done case taking in person. You've done it over the phone. You've done it over the internet, video sessions. You now start with pro forma and photos only. You don't even talk to the patient, until they've taken their first remedy. I'd love to know what you think the benefits of all of those different methods are and what you've learned along the way.
The benefits of doing a pro forma first is speed.
Yeah.
Right. That's a pragmatic thing. I'm not suggesting, though, that it's every bit as good as when you talk to someone. But when you're running a clinic where I think you said to me we have over 100 patients just on the waiting list alone. I remember someone saying to me one time, this was when, these real homeopathy almost started getting self-confused as to whether or not it was meant to be homeopathic or whether or not it was meant to be cognitive behavioural therapy, and it was just sort of trying to find this central core to the psyche. And someone said to me, well, I just have a patient, if it takes me 3 hours, it takes me 3 hours. And I think, well, you can't have much of a waiting room if that's the case, because I am working on the dot, man, as you know. Yeah. I mean, right down to the minute, and the next person's there. And I'm not like a Western medico that doesn't mind keeping you waiting an hour and then just, I like to try my best to be on time. And usually within a 5-minute radius, or range, I should say, I am. But so to try and get people into the system, we developed the Performer. Now, the Performer is not as good as speaking. Well, when I say face-to-face, it doesn't have to be face-to-face. It can be over the phone, but a fluid conversation is better than a more stagnant written consultation. But we still get a lot right.
I'm going to say it depends on the patient. If you get a patient that really focuses on one thing only, and particularly if they've got an emotional connection to it, and a lot of them spend a lot of time going through what the medical profession says about what their problem is, which isn't actually all that helpful to finding a homeopathic remedy and takes quite a bit of their time, I would suggest that the Performer is a really good starting point. Like that you can get some rubrics that are written down there that you wouldn't even pick up in your first conversation.
Yeah, well, maybe you're right. I mean, it's no, you're probably right there. Maybe now I'm sort of chasing my own tail here, but you might be right, because the first consultation, even if it was face to face or over the phone. Normally what you would need to do is a lot of that first consultation is educating people into what they need to look for. So you weren't going to get that far with that one anyway. You really, your starting point is almost your second consultation, unless people are very aware of what you're looking for.
Well, that's what you're doing all the way through the process. I mean, that's good case management, is helping the patient to recognise their own relationship with their symptom pattern and their environment.
Yeah. So when you were talking about how did you introduce this?
Well, it's just asking you, over the years you've done it so many different ways. This is the case taking. What do you think the benefits are of in-person or Performer, or the disadvantages? I mean, look at it from different points of view.
Well, like last week when we were talking about what makes up a good course and what's important in a case. Well, I guess that's where your first consultation is either you've got those points already on the Performer, or a person is aware of what they need, or I can ask them questions that can elicit that. But often they don't know. So you're right. In that sense, I'm going to backtrack. You're right. I mean, the Performer as an original starting place is probably no better or worse than an original face-to-face.
And it depends on the person filling it out. Some people put a lot of information, which is helpful information. Others put a lot of information that is not helpful information. Well, this is the thing. Others don't put much at all, which is not helpful.
Many times where I've said, okay, tell me about what you're getting. And look, you could be 15, 20 minutes in and I'm doing is jotting down drug names of what different people have put them on. And you just, okay, it's time to stop this now. I don't say that to them, of course, but I just say that, all right, I've got this, but now I need to move on to what are more pertinent things for me.
For choosing a remedy.
So, in that sense, I mean, in the Performer that we have allocation boxes for the different conventional medicines, previous homeopathic medicines. We do ask for better falls and worse falls and things like that. But again, first timers don't really know what that means. So often what they'll do is that they'll just write stress or something like that. So I need to know, well, what kind of stress do you face most? Like when we were talking last time, and I think we were talking about the problem with the mentals, and then we were quoting Franz Vermeulen, who was sort of talking about how, I don't know, they can be a little indecisive. They're not as concrete as what people would like them to be. And I think the personality profiles that are written around that are nowhere near as concrete as what practitioners would like them to be, which is why I don't like them at all. Nat Mur, case in point, I think we've done this before. When you were talking about Sabrata last week and how one of his uncles knew Alan, and I was asking TF or JH Alan. Actually, there's a third Alan, isn't there? Yeah. There's a third Alan, the guy who wrote the Myers-Maddox book.
That's not Timothy. No, that's JH.
JH did the keynotes, didn't he?
And he did Pseudosora and whatever. You got some of the
No,
stuff.
I think they're two different people.
Oh, we'll have to look that up, won't we?
Anyway, no, I'm pretty sure they're...
I'll make a note. Look up the Allens.
I got a feeling there's
a Timothy.
Timothy Field, that's
TF,
and he wrote this...
John Henry. I don't know who the third one is.
Oh, maybe I've got the mistake.
Doesn't matter. That can be next week.
Well, maybe the keynotes is... Or is there an HC? That comes
There's
into my head
definitely Alan's keynotes, definitely.
And I got a feeling Nat Allen is different to the miasm and pseudosora.
Right.
J.H. Allen wrote miasms and pseudosora. I think.
He's one of the three that you always pay tribute to in setting up the idea of the face.
T.F. wrote all of the 10-volume encyclopedia.
Oh, that's right. Yep.
And then I think it's HC or something like that.
But it's Alan's keynotes.
Anyway, it's Alan's keynotes. But he's a different Alan, I'm pretty sure.
Okay.
Anyway, now I'm completely off track.
Even I've forgotten where you are. Okay.
I know in T.F. Allen when he talks about Nat Mur and the provers of Nat Mur, and you know how we've built this huge profile about the stoicism of Nat Mur. That was based on one person, one prover.
Right.
What happened to the other 9?
I don't know.
The other 19. I forget how many there were.
You know, some homeopaths go right back to the provings. But the thing is, here's the thing, in the clinic, and going back to what you said, once you get busy, and you should be busy, people should be word of mouthing like crazy how good you are. And I'm really proud to say that they do for you and others that practice HFA really well. You really do get clinical referrals fairly quickly because it's impressive.
Well, we don't advertise at all.
No, we never really have. And and I mean, it was always sort of at a low level solid, but it just really has picked up enormously. Social media, people talking to one another about, this person and that person, and this one helped me and that one helped me. Look, I'm going to shout out a little compliment to you. I remember you telling me this one day. You asked some patient, I don't think you asked them anymore, but you did at that time, where did you hear of me? On some forum somewhere or other that you never heard of. And she said, I trolled through every comment about every homeopath that people had recommended on there. And your name was the only name where no one ever said anything negative. And you sort of said, well, thanks for that. I remember you telling me that story and I thought that was quite funny. But that's what patients are doing out there. They're talking to other patients, and it's up to us as clinicians to keep the standard high, to be respectful, and to aim for the quickest, best result as soon as you can get there.
Oh, absolutely. That's exactly what you're trying to do. And that's why homeopathy should never just be an intellectual exercise. It's on the earth for a very pragmatic reason. And I think for all those that just want to do it as an intellectual exercise, that's okay if you're a student, but then don't sort of write articles and do things that kind of purport you to be,
It promulgates this sort of theoretical homeopathy before practical homeopathy.
Yeah. You only ever know you're right when someone comes back and says, when we go through the checklist and the checklist is just tick, 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 then you know your theory was right. And even then, at the first 100 or so, it still should only remain a theory. Then you start expanding on that theory. But all the way, I've never been afraid of sort of stepping to the left or right of how we should practice. But it's always been guided by either the success or otherwise of the return visit. And when the return visit continuously proves a theory, then I start modifying that. And what I do then is that I start building up a philosophy of why. So homeopathy was quite different. HFA is quite different in the respect that it didn't have the philosophy first, as you well know.
Yeah.
We just did the clinical application of it. We did a variety of different applications, and then the ones that were repeatedly successful were the ones that we clinically adopted, but now we have to write a philosophy to explain why it was so continuously effective. And even then I'll admit that the philosophy is my take on it. I can't sort of say exactly this is what's happening because we're talking about an ethereal world. But it's a way that I can explain what is happening out there in the clinic and then reapply it and get the same results.
So if we go back to case taking, I'm just mindful of some of the people listening that really are thinking, I would like to study this, but it sounds different, and difference can be confronting. Some people are very excited by difference and they embrace it, but a lot of people like things to stay the same.
I'll tell you what, mate, it's nowhere near as confronting as having a patient look at you and going, nah.
Nothing happened. That's confronting.
Nothing happened.
Yeah,
Nothing happened.
Yeah.
Now, I remember the days with conventional homeopathy.
What do you mean by conventional?
Conventional as in trying to find a bit of a personality profile and a couple of what you would normally call classical homeopathy, where you would, I remember times where you were almost willing to give it up. Because I had other strings to my bow. I didn't need to put myself through the rack of homeopathy where patients are looking at you and going, no, nothing happened. No, thanks for trying, but no. And then you'd get this hit and it would be so elating.
And so different.
To the norm that you think, hallelujah, you're almost sort of screaming eureka. And that hit, though, would be so massive a change that it inspired you to keep going because no other modality could rearrange everything in the body with one single pill or one whatever, I mean, it was really phenomenal. But now I'm thankful to say that when somebody is going, no, nothing happened, and doing that, 2-3 weeks in a row, that's the anomaly. Rather than the hit being the anomaly, now not getting it is the anomaly. And that whole difference is HFA and understanding how energy works and how to apply it. And then what I do is that I inform all patients. You know how you were talking the other day and you were talking about how certain lecturers always used to, not even necessarily in homeopathy I'm talking, so I'm not sort of pointing a bone here, but there's a group of lecturers in any profession that always like to hold knowledge back.
I think it's in all professions. The talk that I was listening to was based around archaeology, and there's some really fresh new ideas in archaeology, which you're interested in as a topic, and I'm quite interested too. And they're not totally proven, and archaeology's hard to prove because it's ancient information, but there are definitely some strong statistical data and information that's coming through that's discrediting some of the information from the past and even the present in the sort of the conventional group of archaeologists, and they're holding on really tight. And the question is why aren't you interested in this new stuff? And then this developed into a discussion on other topics where people are saying, but this is common across all topics. Teachers at the top of the hierarchical tree hold on to the ideas they were taught and tend not to deviate from them because in some way their ego or their position,
otherwise they're a student again.
Yeah,
right?
Yeah, it's impossible for them. And I know we were at a conference once and there were a bunch of teachers there and all were talking, and one of them said something that you kind of whispered to me later you weren't overly happy with. And this teacher said, I always like to hold a little bit of information back, from my students because, just to remain the teacher. And so, you say what you said to that.
Oh, well, I just thought it was bollocks. I think that knowledge that is kept is knowledge that's wasted, really. I think you need to share everything. And I do it all the time with patients. I will give as much information as what they require. Now, I don't try and lecture every patient. They have to ask. But when they ask, what do I think is going on? Well, then I give them both barrels. Because
and you don't have to say, I'm absolutely 100% sure.
No. But what I am, it becomes really important, particularly because we're not used to understanding human beings as energetic beings, and we're not used to understanding remedies as energetic remedies. And I'm talking about patients here, not homeopaths or students, and I'm not even going to get into the teachers. This whole thing of science advances one funeral at a time. You honestly, the adoption of new, even if they're better ideas, is so painstakingly
Well, if you look at the history of just adopting new ideas in any profession, the average is 25 years for a new idea to get some traction, which I'm quite excited about because we are in year 25 this year. And there's actually been a real bit of an uptick, bit of an upswing. I mean, the patients have been ticking along for years, and getting more and more and more. But the students, there seems to be a fresh lot of, I'm assuming just younger people that perhaps have been born into a world where independent and new information is not frowned upon. It's actually scientifically valid to go looking at other ideas and test them. So, I mean, that's where we come in. And once you test HFA, if you test it properly, I don't know of anyone that's gone back. I'll put it that way.
No. But they've got to be done. They've got to be done properly, though.
Yeah, of course.
I mean, that's the thing. Anyway, the main point that I was trying to make was it's really important to give that information to a lot of patients, particularly parents, because understanding that energy balance between energy drops, signs and symptoms rise, have a look at the stressors that are around. It could be, dentition, it could be illness, it could be a whole range of different things. But then understanding now all what we have to do is just put the counterweights onto the one of the sides of our scales to balance it back out again, which is equal homeopathically to increasing the frequency of the right remedy. And everything sort of comes back on track. So there's lots of different there's lots of different philosophies that I impart about how this works. And most of it's really understandable. And so where that becomes important, I've got people that do this all the time. Now, I got to stress, you've got to be on the right remedy first, right, for this example. But I've got so many patients that will tell me that, my eye or my kid came down with X, over the weekend, and I was going to send you the email, but I thought, no, hang on, I think I know what he's going to tell me here. What would Grant do? And so I did that, and sure enough, it works. And this is like, for example, if somebody's, I'll just choose a remedy like I don't know, you were talking about Fossack last week, so Fossack, or this week, whenever it was, but I got Fossack in my head. So phosphoric acid ends up being this person's constitutional. They get sick. Now what you do is you just repeat that dose every 2 waking hours for about 24 to 48 hours, maybe one day more if it's really needed. And that does a couple of things. One, it works indirectly on the system. So what I'm saying is that, you know, when you do acute prescribing, that's meant to be a direct for the illness, right? So if you've got hand, foot and mouth, or the kid gets scarlet fever or something like that, you've got your belladonnas or you've got your mercuries that are meant to be specific for that particular illness. But a lot of patients and a lot of parents don't have that stuff on hand. And so by the time they order it and they get it, they're sort of 4 to 7 days down the track. Well, that's too late. So what you can do is you can work in an indirect way. And that is that you can give the Fossack if it's been a very successful constitutional remedy for that child or person. And now you just repeat it as necessary to what you consider to be the energetic drain placed on that person. Because, for example, if you get an acute illness, I mean, one of the first things that happens when you know that you're coming down with something is that you become far more tired than you normally would be. Now, this is your body trying to slow you down. It's trying to stop you spending energy, because what it's needing is all available energy going into the disease-fighting response. So it tries to shut down all the other areas by wanting to put you to sleep or putting you off your food. You don't eat as much because digestion takes a lot of energy to do. So it's just trying to use, and so now what we have is that by supplying the body with that surplus that it needs right at that time, it not only gets over it quicker, and that's why I mean it's an indirect way of treating illness, but because it's been a good constitutional, it gets you back on your feet without any legacy lagging over.
Well, basically helps your immune system to work faster and harder.
And more completely.
Yeah, and so it's a lovely way of dealing with not all acutes. Some are really specific, like your chickenpox and measles and so forth, but that kind of generalized acute where, you know, it's hitting your throat, your ears, your nose, your cough center, whatever, those sort of standard virusy things. Most patients do pretty well on rapid dosing their constitutional, and, you know, you very kindly teach them what to do, when to do it. One of the benefits too, and I'm going to add this in to anyone who runs a clinic, one of the things you get with the homeopathic clinic is there's a lot of questions from patients. Questions about dose, questions about symptoms that are occurring, things they've thought of that they didn't mention, lots and lots of things. You can get very email busy, like ridiculously busy. And one of the things I've really respected with you as the numbers have gone up and up and up in your clinic is how few emails you get on a daily basis compared with, say, 15 years ago, because you teach patients about themselves and what to do when these crises occur, and you give them a guide. And so by the time you talk to them at their follow-up at 4 or 5 or 6 weeks, and you just say, how was that last month? They can say, well, look, there was a time I needed to rapid dose just for one day. You ask what happened. They'll tell you. And you say, well, was it an okay outcome? And they said, yeah, I felt okay by the day 2. I had to rest a bit. And as you would expect, we are not meant to soldier on. That's corporate propaganda, by the way, to keep the workers going when they're sick and also to get them to keep buying the drugs. We're meant to have a rest when we're sick. That's what we're designed for. And it's okay, but you just don't need a week or 2 off, hopefully just a day or 2, depending on the illness, of course, and your state to start with. But I'm really respectful of how you've taught your patients how to manage themselves. And they do really well because it's very simple, straightforward in information.
Well, because once you understand the energy model of it and see ourselves as in that energy model, it's actually not rocket science. It's actually pretty simple. It's really just energy out versus energy in. If there's too much going out, then all your weak areas start to exhibit a pathology. So now what you've got to do is you've got to be able to balance that out with the right energy. Now that's where the signs and symptoms tell you, because everything about human beings is designed to be self and non-self. Doesn't care about anything else. It's very egocentric in that sense. It's not inclusive at all. That your immune system, every part of you is just self, and everybody else and everything else is just foreign. And what we've got to do is we've got to come up with the right energy, what we call self-energy. Now, the way you know what self-energy is by the sum total of the signs and symptoms, or the way that your body's trying to harmonise itself again and bring itself back into balance. Now, there's signs and symptoms, but it's not every sign and symptom. This is the key. Right? You have to understand what is a common sign and symptom of one particular illness to what isn't. And what isn't is what's idiosyncratic, and what's idiosyncratic is what the homeopath needs. Right?
Can you define idiosyncratic specifically?
Well, for someone to come in with arthritis, or let's just say they've got rheumatoid arthritis, and you ask them to tell you about it, and they say that their joints, both small and large, so their hips, their fingers, their toes, depending on how badly affected that they are really painful and sore. And they're losing a lot of power. They can't open jars anymore. They're losing a little bit of mobility. That pannus formation is starting in their joint, meaning that the architecture of the joint is starting to become a little deformed. So now what you can do is you can get signs and symptoms like inflammation. You can get pain, heat, red, which is all what inflammation is. You can get worse being knocked, or, worse beginning motion. But they're all standard, right? They're all standard stuff. But if a person then turns, and even to some degree if they say, if I drink alcohol or eat a lot of sugar or eat bad food or I get really tired, all those things they're just inflammatory promoters. So you would expect that inflammation on inflammation is going to make things a lot worse. But if you then turn around and someone says, my neck is really bad, it's hit me in my spine, I'm much better for arching right backwards, or I'm much better for someone else putting a lot of hard pressure on my hands or on my knees. Now that's more unusual. Now that I don't know how that patient's body is deciding that better for hard pressure is in its best interest. That I don't know. But I know that they've got it. And I know that it isn't part of the rheumatoid picture.
Which makes it idiosyncratic.
Which means that it's exactly what I need.
Yep.
So
that's individuality.
That's the individuality. That's what I said last time we spoke. The individuality of the patient is important, but individuality in practice is not really.
Individuality of symptom presentation. So if we go back to the core topic, if we just loop back to the beginning, which is case taking, and you're saying the performer's a very valid way, but in person you can certainly pick up a little bit more in certain areas, which may or may not be helpful. Just depends on the.
Well, you can ask people to qualify a little bit more, I suppose. Yep. But then by the time they're qualifying, I don't have 3 hours.
Yeah, you've got 30 minutes.
By the time I get them to qualify, yes, it's better on the one hand than the performer, but on the other hand, we may not get through as much information as
I think there's a real truth in that, I've noticed, because the performer's about 5 pages long, and if they fill it out, with a sort of a moderate amount of information, like not excessive but not too light either, and you glance your eye down, you might just see that they have some really peculiar issue with their bowels that isn't part of the presenting complaint. But when you read it, you go, wow, that's a bit different, idiosyncratic. And so straight away it becomes a rubric, and they only just had to write it down. It probably would not have come up in that conversation. Look, it would have if you're allowed 2 or 3 hours, most likely, because people run out of things. But in 30 minutes, it's not so likely. So the performer's quite valid. And, case taking, it's about the main complaint and any unusual presentations associated with that complaint, and any allied complaints that are also a little unusual, or maybe they're just a decent craving for food or a very persistent modality that might be sort of normal, but, at the same time it's so persistent and so distinctive in that patient's case that you really think, I should put that in. And that's what good case taking is all about. Did you want to add any more to case taking?
No, I think that's a pretty good summary. If you know how to repertorise, you know how to take a case because you know what you're looking for.
Yeah, the two are linked.
And the other thing too, though, one of the things that we used to get taught, which I don't think is right, is that we should just sort of be this empty vessel and
just listen
and not lead.
Yeah, no,
I don't agree with that.
So much better when you lead.
Yeah,
you get so much more information.
Well, but in order to lead, you need to know where you're going,
and you need to listen. So it's both. You need to listen and to lead at appropriate times.
But it's not just, gee whiz, tell me everything about you and I'll try and work something out at the end. That's not how this goes.
You'll be overwhelmed.
You will. And some people will give you absolutely nothing, and some people will keep you there for 8 hours and they're only halfway through. And either one is not good for you.
No. Balance.
But if you need, that's right. If you need to, as a homeopath, when you're talking about case taking, it's almost an extension of repertorisation.
Yeah, I think that's a good point.
You need to. Repertorisation is the foundation of the whole thing. Yeah. If you can't do that, you can't do the system. You're taking a guess, and then maybe you might get it right every now and again. But that's not what we're talking about here. We're talking about a practitioner that needs consistency. And if I've got 100 people waiting just to get in to speak to me, and this is not even our busy time just yet, then so could you as a practitioner. You could have the same thing. It's not like the world doesn't need it. The world needs good practitioners. So, but in order to be that good practitioner, like you said, case taking is a really important part. But you can't be a good case taker if you don't know what you need.
Yeah.
Right? And what you need is wrapped up in your ability to be able to repertorise.
Yeah. I reckon that's a great summary. So I know we digressed a bit, but it is important to remember the core components of clinical success. And
did we define repertorisation?
No. We'll do that separately. Let's go for that next time. I'll make a note. We've got to look up the Allens, and I'll put down repping for our next podcast. But, I think that the case we teach all this in the course, obviously, but it's just something for people to listen to because not everyone's taught the same way.
No, I know.
Okay.
Okay.
You look like you're finished.
No.
You usually wrap things up, so it's up to you to, do the finale.
No. We've only been going 15 minutes or something, haven't we?
I don't think so, but
Have we?
I don't know. I'm not sure.
Hey, all right. Are there any other questions?
Let's make it. If it's going to be short, it's short today. We'll make it longer next time. There you go.
All right. Well, we can do that.
Unless you want to talk about case taking, if you've got anything to add that you haven't already mentioned, that was the focus that I was, really wanted to make part of this podcast.
Oh, look, no, I think I've probably covered it. The only thing, other thing that I would say about case taking is to understand what you're there for. You know, when we went to, I'm not going to say who, but we went to a lecture and it was somebody being videotaped and some of the audience were laughing.
All right. Yeah, I think I know what you mean.
Because the person in their eyes, the audience's eyes, were...
You mean the patient being videoed?
The patient being videoed was just such a caricature that they couldn't, of whatever remedy it was
supposedly, yeah.
That they couldn't help but giggle and...
yeah, I know what you're saying. It's really disrespectful. Patients are there for you to help.
I walked out of that furious.
Yeah, I know you did. No, and unfortunately we're going off on another topic here. We nearly finished, but homeopathy is not theatre. It's not the theatre of psychology.
This is the point that I was going to say, is exactly that. Patients are not there for you.
No, you're there for them.
And you are there for only one purpose. It's not that they are there to entertain you and to show you how advanced you are because you knew them better than they did. No. Even as they were walking through the door, aren't I just spectacular?
No.
I really hate that stuff.
Yeah, because it's so egocentric. It's horrible. But being a health practitioner of any kind, and we hear this because you've got a number of health practitioners as patients from different modalities that use homeopathy to support them. And one of the common things they say is it's quite hard dealing with people, number one, let alone sick people. It's a difficult thing to do, to put yourself out there to help other people. And you've got to help yourself as well. You need to be a healthy practitioner.
The other thing too is that, and this is where I'm going to differ from Kent, right, is that my baseline is the central pathology that someone comes to me with.
Yep.
That is my measuring stick. I must improve that central part, that problem. Right?
Yep.
Because remember, even in Kent's lesser writings, I think it is, or it might be the philosophy one.
I couldn't tell the difference.
I don't know anymore. I know what he says, but I'm not as good as where he said it.
You haven't read it for probably 25 years, so.
No, and I never really tried to sort of do the whole, if you turn to page 24 of this book stuff, So I've never bothered to do that. I've always just thought, just as long as I understand what they're trying to say.
Yeah.
But in there, in one of them, I got a feeling it's Kent's philosophy. And he talks about it doesn't matter whether or not certainly at the beginning, it doesn't matter whether or not the pathology is improving provided the person's feeling better. Now, I absolutely disagree with that. Absolutely. To me, you must, as a practitioner, you have to sit down. Look, if I was going to a chiropractor for my headaches and he didn't fix them, well, then I would consider that not effective, right? So you need to be, I think in order to be an effective practitioner, you need to understand what it is that you're trying to deal with, and that becomes, what you measure your success.
No, absolutely. And we can talk about that in case management. I would really like to, we've glossed over case taking, and you could go on for hours about different cases, and maybe down the track we'll pull a few cases, get some patient permission and discuss them, no personal details, but just the general way the case presented and what happened. But it is divided into case taking, case repertorising, facial analysis, and case management. These are the core areas that you have to know, and homeopathy is a wonderful thing to learn for self-reflection and understanding of much bigger pictures than us. But at its core level, it is a practical methodology for helping patients.
It has to be. Yeah. It has to have that practical outcome. But when you talk about the facial stuff, without the facial analysis, you are seriously guessing, man.
Yeah, it's pretty hard. It's pretty hard, no doubt about it. You'll get hits. Obviously, we all have and will and do, but you just get really good feedback on people who start using the face and how the consistency they start to experience and the confidence. That's such a huge thing. You have to be confident, and we'll talk about that next time. Hey, that because you mentioned Kant, and it just came into my head, and I made a note about what he says you need to be a good practitioner. We'll talk about that next time.
All right. Okay, well then we'll leave it at that, and we'll see you all next week. Okay, bye everyone.
Bye-bye. Thanks for listening to Soul and Survival. If you are interested in more information, books, courses, consultations, learning more about facial analysis or life themes, please visit our college site, Victorian College of Classical Homeopathy, vcch.org.